Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium. Thank you.
Good morning. My name is Stephen Sener. I am the Chief of Surgery at the LA County Hospital, LAC+USC in Los Angeles. It's my pleasure to be speaking to you today about advances in axillary surgery over the last number of years. I'd like to share with you my thoughts on advances in axillary surgery. This talk was actually given a couple of times in the last several months. One was at the 8th World Symposium on Lymphedema Surgery in Taiwan in April 2019, and most recently in June at a USC multidisciplinary conference hosted by Dr. Ketan Patel. So the goals of axillary surgery for breast cancer are to control regional node disease, to guide systemic treatment, and to a certain extent to improve survival rates. Over the last 3 decades, modifications in systemic and radiation therapy have had significant contributions to a marked reduction in the regional lymph node recurrence rates. This table illustrates the remarkable difference in regional recurrence rates between an older trial of surgery alone, the NSABP B04 trial, versus more recent trials, in which the vast majority of patients received both systemic and radiation therapy after a sentinel node biopsy demonstrated regional node metastasis. These are the Z11 and the AMAROS trials. With the advent of genomic profiling of breast cancers, it's now possible to stratify even further the risk of regional node recurrence using the Oncotype DX recurrence score. Although the 21 gene recurrence score was developed to estimate the 10-year distant disease-free recurrence rates in node-negative ER-positive patients, the recurrence score has also been shown to be useful in determining the risk of local and regional recurrence in node-negative patients. But a similar association demonstrated between recurrence score and the risk of local regional recurrence in node-positive patients treated with adjuvant chemo and endocrine therapy was shown in the NSABP B28 trial. This was a prospective randomized trial that tested chemotherapy. The specific question was whether the addition of Taxol to adriamycin-based chemotherapy would improve survival compared to adriamycin alone. Patients with ER cancers also received tamoxifen, but nobody in this trial got radiation therapy. And you can see in this graph that on the left-hand side, for patients who had 1 to 3 positive lymph nodes, the recurrence score was not able to discriminate the incidence rates of recurrence. However, if patients on the right-hand side had 4 or more positive lymph nodes, the recurrence score was actually able to demonstrate that certain populations of patients were at significantly high risk to recur. So a high recurrence score was associated with a 20% recurrence risk, whereas a low recurrence score had a very low risk of recurrence. This is pretty important because patients with 4 or more positive nodes were thought to have a poor prognosis, but you can see here that the recurrence score actually stratifies this risk fairly nicely. Well, even as therapeutic strategies continue today to modify the risk factors associated with lymph node recurrence, the risk factors for post-treatment lymphedema, or secondary lymphedema, in this case related to breast cancer, have been known for some time. The extent of the axillary operation and the extent of the chest wall or regional node radiation are well-known risk factors, but in addition, other categories such as overweight or obesity at diagnosis, weight gain after the operation, and the presence of infection or injury after operation are also risk factors. I'd like to describe now the advances in therapy to reduce the risk of lymphedema, looking at patients who present with new primary cancer and have a clinically negative axilla. They are about to undergo a sentinel lymph node dissection. Advances in surgical therapy to reduce the risk of lymphedema actually started in the middle 90s with Morton and Giuliano using the sentinel lymph node dissection technique. They used vital blue dye, and these techniques were designed specifically to accurately stage the lymph nodes draining the tumor with less morbidity than an axillary lymph node dissection. Shortly thereafter, techniques for lymphatic mapping and sentinel lymph node dissection using radio-labeled microparticles detected by a handheld gamma counter were developed. You can see one of our early lymphoscintigrams on the right here, and using the blue dye at the same time, you can see in that patient the mapping of the lymphatic leading out of the breast up into the axilla. Well, the ACOSOG Z11 trial was a landmark prospective randomized trial that was started in 1999 to establish whether a sentinel lymph node dissection alone was associated with survival results that were better than those with axillary dissection. The patients in this trial had tumors up to 5 centimeters in diameter. They had clinically negative lymph nodes. They had a sentinel node biopsy, and the sentinel node biopsy revealed 1 to 2 positive lymph nodes. All of these patients received a partial mastectomy or a lumpectomy. They had whole breast radiation, and because the lymph nodes were positive, all of these patients, virtually all of them, got systemic treatment. And you can see here, after 9.25 years, really good long follow-up, the overall and the disease-free survival rates were not significantly different between the two arms. But really important in the middle of this slide was that the regional node recurrence risk for axillary dissection was only 0.5% in the axillary lymph node dissection arm, and in the sentinel lymph node dissection arm, it was only 1.5%. It's important to note that these recurrence rates were statistically about the same, even though 27% of the patients in the axillary lymph node dissection arm had regional lymph nodes that were found at the time of the pathologic evaluation. The clinical implication for this finding is that the residual positive lymph nodes left behind in the sentinel lymph node population alone were adequately treated with systemic therapy and radiation therapy. And the conclusion from the trial was that sentinel lymph node dissection alone provided excellent regional control compared to axillary lymph node dissection in patients with 1 to 2 positive lymph nodes. Well, in the ACOSOG Z11 trial that we just discussed, the inclusion criteria relied on clinical examination of the axilla. However, at the same time that trial was done, other investigators, including ourselves, determined that ultrasound was actually an accurate tool to stage the clinically negative axilla. And this was done to lower the false negative rates for sentinel lymphadenectomy. Basically, what happened was the patient had an ultrasound. A core biopsy was done of abnormal lymph nodes, if any were seen, and a small microclip was actually placed in the lymph node. The lymph node was then wire localized, and it was removed through a sentinel node technique. And then we took a picture, which you can see here, to identify that the positive lymph node, or the discordant lymph node, had been removed by the sentinel node biopsy. This is the wire that we use. It's a flexible wire, as you can see here. And it's like a wound radial wire. It doesn't hurt, it doesn't migrate. So this is really a good way to localize both breast tumors and sentinel lymph nodes. And what we decided was that patients with a clinically negative axilla still met the Z11 criteria if we removed a wire-localized node and it was positive for cancer, but it was also a sentinel node. And as long as there were less than 3 positive sentinel nodes and there weren't a lot of matted nodes stuck together, we thought these patients still met the Z11 criteria. Well, success with the sentinel lymph node dissection for patients presenting with a clinically negative axilla led to a new trial in which patients with positive nodes prior to therapy actually had preoperative chemotherapy, and if they had the development of a clinically negative axilla, they were then allowed to have a sentinel lymph node biopsy. This was a clinical trial run by the American College of Surgeons, ACOSOG, and it was called Z1071. And basically, in this trial, there were 525 patients who had 2 or more sentinel nodes examined using not only blue dye, but radioactive tracer. In this trial of patients who got preoperative chemotherapy, after the chemotherapy, 41% of the patients had no identifiable cancer in the specimen at the time of the operation. However, the false negative rate for the sentinel lymph node biopsy was 12.6% in this trial. That means that the sentinel node biopsy was not able to adequately identify positive lymph nodes. So the 12.6% false negative rate is way too high. It should be in the 4 to 5% range. So a number of us actually who put patients into that trial actually tried to help figure out ways to lower the false negative rates. You can see from this table, the ACOSOG Z1071 results are on the left, but there were 3 other trials that were done. The most recent is a French trial called GANIA-2. And you can see that the false negative rates for all of these trials together are in the 12% range. So even aggregating data from multiple trials, the false negative rate for sentinel node biopsy was still way too high. If multiple tracers were used, blue dye and radioactivity together, the false negative rate dropped somewhat, but it was still excessive. So techniques to actually increase the accuracy of sentinel node biopsy after neoadjuvant therapy have been developed. Some people use microchips, as I've previously described. Some people use radioactive seeds. And we actually put a number of patients on this trial using the wire localization technique. So Dr. Bowie went back and analyzed the patients from Z1071 who had wire localization of abnormal lymph nodes. And you can see that if the clip, which I previously described, is put in the lymph nodes that are abnormal using ultrasound, if you use that wire localization and ultrasound technique, the false negative rate drops to 6.8%. So it's starting to drop, but it's still a little too high. At the University of Southern California, a clipped node was the sentinel node in 3/4 of our early patients. At MD Anderson Cancer Center, Henry Curer and his colleagues actually also did a localization technique. Early on, they used wires, but then they switched to I-125 seeds, putting them in the abnormal lymph nodes prior to chemotherapy. Then if patients had a good response to the chemotherapy, they were candidates to have a sentinel node biopsy, even though they presented with a positive lymph node at the time of the presentation of the cancer. Dr. Curer recently has shown that if you just did a sentinel node biopsy alone in his trial of 191 patients, the false negative rate is about what it was in Z1071. However, if you did a sentinel node biopsy plus using the clipped lymph node that I just described, the false negative rate drops to really low levels of 1.4%. What we've all learned from this is that sentinel node biopsies after preoperative chemotherapy do work. The false negative rates for the technique can be lowered by using pre-treatment staging with an ultrasound, core biopsy of abnormal nodes with the placement of a microchip, using 2 tracers to identify the lymph nodes by sentinel node technique, and a careful dissection of the sentinel nodes increases the yield. And once you take the lymph nodes out, you use image guidance to make sure that the clip is included in the specimen that you've removed. We're now currently in the next generation of clinical trials of patients treated with neoadjuvant chemotherapy who start out with a positive lymph node, who convert to a clinically negative axilla. We have 2 trials for these patients. One is NSABP B51. So if you do the sentinel node biopsy, if the sentinel node is negative, patients are then randomized to either regional node radiation of the lymph nodes versus no radiation and no further axillary dissection. Think about this. The patient comes in with regional nodes that were positive, gets chemotherapy, has a negative sentinel node biopsy after chemotherapy, and can get randomized to no further radiation. We've come a long way in de-escalating therapy for patients who present with positive lymph nodes. On the other hand, the second trial is the Alliance A11202 trial, which takes patients who still have a persistently positive sentinel node. They're randomized to lymph node dissection, an axillary node dissection plus radiation, versus axillary radiation plus regional node radiation. So this trial is actually going to test whether radiation can supplant surgery for positive node patients. Well, I'd now like to switch gears a little bit and talk about axillary reverse mapping. So, although sentinel node dissection was designed to reduce the complications from axillary lymph node dissection, short-term studies demonstrated that the risk of lymphedema after sentinel lymph node dissection alone was still in the range of 2 to 7%. So, Suzanne Klimberg and her colleagues hypothesized that variation in arm lymphatic drainage patterns put the efferent lymphatics from the arm at risk during an axillary node dissection, and to a lesser degree during a sentinel lymph node dissection also. So they devised a technique called axillary reverse mapping, and it maps and facilitates the preservation of the lymphatics draining the arm using vital blue dye, and you can see this blue lymph node in the field here. The blue dye is injected into the skin of the upper arm just prior to the operation, and over a period of about 15 minutes, these lymph nodes that are draining the arm turn blue. At the same time, the radionuclide is injected into the breast just like we do it normally, so that the lymphatics draining out of the breast map to the breast sentinel lymph node, and the blue dye coming out of the arm maps to the arm sentinel lymph node. Well, Suzanne Klimberg and her colleagues have recently published their experience with 685 procedures. They've identified standard lymphatic patterns of drainage using axillary reverse mapping, which you can see in this slide. They're 5 known patterns of drainage from the arm. And if you look at their results for the first 685 procedures with about 2-year follow-up, the most important thing on this slide actually is the fact that the risk of having a hot blue lymph node is in the 4 to 5% range. What that means is that the lymph node that drains the arm is the same as the lymph node that drains the breast. And so the sentinel node that you're removing to make sure that it doesn't have breast cancer is the same central lymph node that drains the arm. And so removing that sentinel node actually increases the risk of lymphedema. What Klimberg and company showed is that the lymphedema risk is actually pretty low over a 2-year period in the lymphedema column. The recurrence risk is low, but actually this was a proof of principle that one could map both the breast and the axilla, and that has led to this clinical trial, which currently is open. This is a prospective trial to study the rates of lymphedema and regional node recurrence with the repair of blue lymphatics that are injured during this operation. So in schema 1, patients who present with clinically negative axilla, if they have a mastectomy, then they have a sentinel lymph node biopsy. And if the lymph nodes are positive, they have an axillary dissection, or they have axillary reverse mapping plus axillary dissection. And this will help us identify whether mapping blue lymph nodes lowers the risk of recurrence or lymphedema. The second schema will take patients who have clinically positive lymph nodes who are having either breast conserving therapy or mastectomy and randomize them to either axillary lymph node dissection or axillary reverse mapping plus lymph node dissection. The key issue in this trial will be that if the blue lymphatics are injured during the course of the sentinel lymph node biopsy for cancer, they will be repaired. And I'll come back to this particular point in my conclusions. Well, there have been a number of trials that have investigated axillary irradiation as opposed to axillary surgery. The most important of them is the AMAROS trial, which just published its 10-year results. This was a trial in which patients who have a positive sentinel node were randomized to either axillary surgery or axillary radiation. So here's the trial design: to either lymph node dissection or radiation. They then went to the operating room and had a sentinel node biopsy. If the sentinel node was negative, nothing further was done in the axilla. But if the sentinel node was positive, the patient went on to either have axillary surgery or axillary radiation. This was a phase 3 so-called non-inferiority trial, and here's what that means. The primary endpoint was axillary recurrence, and it was expected to be about 2% in the axillary dissection group based on multiple clinical trials that were done about 10 years ago. However, if the axillary recurrence rate was not more than 4%, in other words, a 2% difference in the axillary radiation group, then radiation would be judged to be non-inferior to dissection. Patients in this trial had tumors up to 5 centimeters in diameter. They had clinically negative nodes at the beginning. Interestingly enough, mastectomy patients were allowed in this trial. Interestingly enough, the radiation had to start less than 12 weeks after the sentinel node biopsy. And what that means in conventional terms is in the United States, our axillary radiation is usually done after the chemotherapy. However, in this trial, the axillary radiation was done before the chemotherapy in order to meet the criteria for the trial. On the other hand, on the axillary node dissection side, patients with 4 or more positive lymph nodes not only had an axillary dissection, but they had axillary radiation, which would be expected to substantially increase their risk of lymphedema. It took 4,800 patients to find 1,425 positive sentinel lymph nodes, as seen here. And then the randomization occurred as I've described it. Interesting that 17% of the patients in this trial had a mastectomy. As I told you, the Z11 trial was done in patients who only had breast-conserving surgery. And in the Z11 trial, patients also had whole breast radiation. It was thought that some of those patients had a benefit from the radiation because the low axilla was probably somewhat treated by the radiation. But here we've got mastectomy patients in this trial. I'll point out that close to 33% of the patients in this trial had positive lymph nodes in the axillary dissection arm. And what that implies is that the same number of patients probably had microscopic disease in the axilla, and they wound up to get radiation in the other arm. And what you'll see here is the axillary recurrence rates were very low, even with axillary radiation. What that means is that the axillary radiation, and because these are node-positive patients, the systemic treatment combined to really lower the risk of recurrence in the axilla. The disease-free and the overall survival rates were the same in the two arms of the trial. The investigators did look at lymphedema, and they made the observation patients who had radiation had a lower lymphedema risk, as you see on the left, than the patients who had an axillary dissection. However, only 2/3 of the patients had valid forms received regarding lymphedema, so the data collection mechanism wasn't actually as accurate as we would have liked, perhaps. The investigators did show that there was a difference between axillary dissection and axillary radiation in the lower arm, favoring axillary radiation. However, in the upper arm, there was no difference in the lymphedema risk over a 5-year period. These authors concluded that both axillary dissection and axillary radiation provide excellent and comparable control of the axilla over a long period of time. Very few people recurred in either arm after 5 years from the operation or the radiation. And the authors claimed that there was significantly less lymphedema in the axillary radiation arm after 5 years. My comments on Amaros basically I've already alluded to. Systemic treatment and radiation once again are demonstrated to lower the risk of axillary recurrence compared to older trials such as ACOSOG Z11. Well, there has been a move recently to omit regional radiation in patients who have low-risk node-positive disease. Last December, the Early Breast Cancer Trialist Collaborative Group presented at the San Antonio Breast Conference an analysis of 13,000 women who had been treated in 14 trials over a long period of time. The value of the Early Breast Trialists group is that they take individual patient data and pool them into a very large trial in this meta-analysis. And what they've shown is that if you look at the regional node versus not in these 14 trials, there were a variety of radiation schema that were used in these trials. But the important thing is this. If you look on the right-hand side, patients with 4 or more positive lymph nodes had a substantial benefit from radiating the lymph nodes. However, patients who had a small number of lymph nodes, 1 to 3, had virtually no advantage to adding regional node radiation, and patients who had negative pathologic nodes got virtually no radiation benefit. And so we're coming to the point that it is possible to select patients. It is possible to select patients who are really going to benefit from radiation versus those who are not. Also, there has been a move to actually stratify patients using the Oncotype DX recurrence score, which I alluded to previously. This is an attempt to omit regional node radiation in patients who have positive nodes but low risk by oncotype. So patients with 1 to 3 positive nodes after breast conserving therapy or mastectomy who are estrogen receptor positive will have an Oncotype DX recurrence score. And if it's low risk, meaning less than 18, those patients will actually be randomized to get either regional node radiation or not. And so this is an attempt to actually de-escalate lymph node radiation for node-positive patients. These patients who are node positive are going to get adjuvant chemotherapy and hormone therapy just like they would normally. So this is another experiment using radiation and systemic therapy to try to lower the risk of axillary recurrence. So when these advances are added to the potential for clinical trials by microsurgeons to reduce the risk of lymphedema after axillary treatment, the promise of significantly reducing morbidity from lymphedema seems within our grasp. I alluded to the Alliance trial previously done by which Klimberg is the primary investigator. What would really be interesting is to now marry that clinical trial using axillary reverse mapping with the really new and innovative reconstructive microsurgery techniques with lymphovenous bypass specifically during axillary dissection. And it is my hope that we can get the investigators from our plastic and reconstructive colleagues to get together with our oncologic colleagues in the Alliance trial and create a process which marries both oncologic and reconstructive principles. Thank you for your attention, and I'll be happy to answer questions. So I've got a question asking what's the best way to evaluate the lymph nodes before surgery? Is clinical exam adequate, in my opinion? As you can see from the presentation, we use ultrasound in addition to clinical examination because we think it allows us to identify lymph nodes that the examiner or the surgeon might not be able to feel. And so using the technique I described, where we actually do the ultrasound and wire localize the abnormal lymph nodes, we have been able to reduce the risk of leaving cancer behind when we do the sentinel node biopsy. So over the last decade, we have used ultrasound as part of our technique to evaluate the axilla. The next question is, based on best available evidence today, what do you think is the best way to reduce the risk of lymphedema after node dissection? Well, that's a good question. So we have all of our patients seen prospectively before the operation. They have their arms measured. They undergo a fairly intensive evaluation by our rehabilitation team. That includes the principles of education regarding lymphedema risk. So we are pretty careful about trying to have patients maintain their weight. We're pretty careful about avoiding problems with the lumpectomy or mastectomy incision. In other words, avoidance of infection in the incision is actually a pretty significant issue. So our patients are all educated. We see them routinely, periodically after the operation arms are measured at periodic intervals. So not only do we have a way of educating people about reducing risk, but we also have a mechanism for early detection of lymphedema in the 6-month to 2-year period after the operation. Is it possible, after the lymph nodes have been removed and lymphedema has developed, to have surgery to reroute the fluid? Yes. So part of the symposium that I gave this talk at, both symposia, were really dedicated to the reconstructive microsurgeons and the treatment of lymphedema. It's pretty hard for me to recapitulate the symposium, but I will just tell you that there are 2 basic techniques that are being used now by our plastic surgery colleagues to treat lymphedema. In one, there's a technique called lymphovenous bypass, in which the obstructed lymphatics of the arm are actually anastomosed or joined to small veins in the arm, which lowers the lowers the lymphatic pressure in the arm. So these techniques of surgery are combined with wrapping and manual lymphatic drainage, standard techniques, to actually treat lymphedema. The other technique that's currently being used is to actually transport lymph nodes from other parts of the body, like the neck, even the abdomen, to the arm. And over time, these lymph nodes that have been transported actually foster the development of new lymph nodes, which then actually also bypass the obstructed lymphatics and drop the fluid into the veins. So these are new techniques that are being used to augment manual techniques that have been around for some time. Actually, I have another thought for Bonnie. So the symposium in Taiwan is actually going to be published in the Journal of Surgical Oncology in January of 2020. And these manuscripts are actually probably available online now. So you might actually start to search for them. And they are the manuscripts from the 8th World Symposium on Lymphedema Surgery, held in Taiwan in late April of 2019. Excellent papers that will in detail explain the treatments using reconstructive microsurgery techniques to treat lymphedema. Well, I don't see any more questions, so I've really enjoyed sharing my talk with you, and I am sure that our colleagues at the Lymphedema and Research Network know how to get in touch with me if you have further questions along the line. Thank you.